Good evening, everyone. Hello and welcome to this support for doctors returning to work in the pandemic session. Our first session today is going to be on interpretation of chest x-rays and CT scans, which is presented by Dr. Sunit, who's a specialist registrar in respiratory and internal medicine at Oxford University Hospitals. Thank you so much for joining us tonight, Sunit.
That's all right. Let me just load up. Hold on. Oh, let's have a look. Right. So this is a fairly rudimentary approach to chest X-ray, and really the main thing is the structure and things to look out for. Before starting, I'd say the key thing for everyone coming back to training, thank you for doing that, by the way, is really try and spot pathology that isn't COVID-19. I think the pressure is going to be on to say we need to treat all the COVID patients, but the reality of these patients is that they're not treatable. We have to support them through and hope that they get better on their own, which means the real savings here are going to be finding people that are in respiratory failure with treatable pathologies. And your chest X-ray is going to be important for that. So the outline of the presentation, it's a structured approach to interpreting a chest X-ray, a brief bit on COVID-19, and then CT imaging. There's really only a brief bit on CT imaging because I don't think it's important for the kind of general medic or the general surgeon or anyone on the shop floor really to know. That's for our radiology colleagues to report. So feel free to share in the chat, but can anyone spot the abnormality on this chest X-ray? So this one actually caught me out, but there's no clavicles. It's quite a difficult chest X-ray. And I think generally you know something's abnormal about it, but just be wary that you're not always looking for pathology, you're also looking for the absence of normality as well. So most importantly, make sure you're looking at the right radiograph. So check the patient details, name, date of birth, hospital number or NHS number. And really, really importantly, a lot of patients, especially when they're critically unwell, will have had many chest X-rays, often in the same day. So make sure you're looking at the latest chest X-ray. And I would press as well, almost everyone you see in hospital will have had a chest X-ray at some point in their life. They always show evidence of chronic pathology. So make sure you're comparing your current chest X-ray to an old one, and that you understand there's kind of the changes with time that have happened over multiple chest X-rays. A very brief bit on assessing your image quality. So the mnemonic that I use is RIPE. So the first part of that is rotation. And what you're looking for is the medial aspect of your clavicles should be equidistant approximately from your spinous processes. If you can see that the medial end of one of your clavicles is, the distance between the clavicle and the spinous process is less than the other side, then it suggests that that side is orientated slightly closer towards your X-ray machine. Your spinous processes as well should be vertically rotated rather than slanting to one side. To assess for adequate inspiration, you're looking for 5 to 6 anterior ribs and 10 posterior ribs. Projection, generally, I think we like to believe that most of our X-rays are PA. That's not really true. In the acute setting, it's quicker for radiographers to do AP films. Traditionally, we've always said that you can't assess the cardiothoracic ratio, so your heart size on an AP film. In reality, when there's significant cardiomegaly, you can assess it on an AP film. The other way of looking is if you can't really see the scapula projected through, then it's probably a PA film. And then the exposure. So the chest X-ray on this slide is really nicely taken. You can see very clearly all the vertebra behind the heart. The structure to sort of my chest X-ray interpretation is A, B, C, D, E, as with everything else. So airway, breathing, cardiac, diaphragm, and then kind of the basket for the remaining things to look for, everything else. And we'll get right into it. So starting with your airway, the first thing to look at is your trachea. And I think it's underdone. It can really bail you out of quite a few tricky situations in terms of working out what an X-ray is showing. So you're looking for pathology that will push the trachea one way or pull it the other way. And things that will push the trachea away from the side of the pathology will be large pleural effusions or a pneumothorax, which is what you can see in this chest x-ray. Now, a lot of people will say this chest x-ray never should have been taken. I would amend that by saying if this patient were hypotensive, it never should have been taken. So if they're showing signs of a tension pneumothorax, then don't do the chest x-ray. Obviously, you'd book one, but in reality, this is a hypotensive patient. He needs a great cannula in the second intercostal space, midclavicular line. And similarly, things that pull the trachea towards it. So lobar or segmental collapse will pull the trachea towards the side of your infection or of your collapse. And that could be usually down to infection or a proximal mass that's blocking off the airways and causing collapse of the lung distal to it. Then moving on to the carina and the bronchi. This is mostly just a brief word. Most adequately taken chest x-rays, you should be able to see the carina. In terms of its clinical relevance, in an ideal circumstance, you want your NG tubes to bisect the carina. So you should see it going straight down the middle of the carina and then all the way below the diaphragm and sitting within the stomach or the duodenum. And similarly, it's worth noting that the right main bronchus, the reason that we tend to aspirate down into the right middle and lower lobe is because the right main bronchus is shorter and wider than your left main bronchus. So it's a more direct route for inhaled foreign bodies or aspiration. The hilar, this often gets very confusing. I think broadly speaking, your hilar is just the conglomeration of your main pulmonary vessels and your main bronchi. The way to think about it is that it's convex in shape. The left hilum is usually slightly higher than the right, and I'll show you in a moment why that's important. And they should really be the same size. The pathology that you'd be looking for is sarcoid TB or malignancy, if you think you can see hilar lymphadenopathy. It's not always easy to see, especially on an over-penetrated AP film. These are normal hilar, and you can see the left hilar point is higher than the right. The reason that's useful, if there is, left lower lobe or left lower lobe collapse or right upper lobe collapse, it will pull the hilar in one direction or another. So you can kind of assess for volume loss based on where the hilar points are. And it's not by any means definitive in isolation, but it's something to look for if you're struggling with the rest of the chest x-ray. And the picture on the right shows you what subtle hilar lymphadenopathy would look like. B moves on to breathing. So in general, I recommend that you split the lungs into 3 zones on each side. So not lobes, but if you take a third of the height of the lung and split it into the upper zone, the middle zone, and the lower zone, it's probably the best way to describe pathology that you can see within the actual lung. Look really carefully for asymmetry and whether that asymmetry is normal. So obviously your left lower zone will look different to your right lower zone because of the heart border, and look really carefully for lung markings throughout the entire zone. And again, you're looking for, is there a coarseness of the lung markings that might suggest interstitial disease? Or is there an absence of lung markings that might suggest a pneumothorax or emphysema? The red arrow looks at some, I don't know if they project nicely, but lines which would suggest reticulation. So that could be fibrosis or interstitial edema. And the yellow arrow is pointing to an air bronchogram that would suggest consolidation. So that's when you've got alveoli filling with exudative fluid or pus. And really all you can see is the bronchiolar airways. This x-ray is actually from a COVID patient. So it's something to look out for. I'll briefly touch on lobar collapses because these can be really subtle. So right upper lobe collapse presents like a wedge-shaped triangle at the top of the right lung, and it can be really, really subtle. So sometimes all you'll see is that raised right hemidiaphragm compared to the left, and just a really small triangle. And I've definitely been caught out doing a CTPA on one of these patients because the chest x-ray looked almost completely normal, and only with the consultant thoracic radiologist the next day did they say there was right upper lobe collapse on the chest x-ray. I mean, he would have needed a CT anyway, but still, it's useful to be able to pick it up. Right middle lobe collapse, you lose the right heart border, and you can get that kind of wedge shape that you can see on this chest x-ray, but not always. So if you can't see the right heart, border, and you think the right hemidiaphragm might be slightly elevated comparatively, there may well be some right middle lobe collapse. especially in the context of a patient who's just choked or vomited and you think may have aspirated. And then right lower lobe collapse, I think, well, I'd like to think that sort of speaks for itself, where you can just see clear lobar collapse with a clear right heart border and an aerated right upper lobe. And then on the left side, left upper lobe collapse. So it really highlights the fact that you're looking at a 3D structure on 2D imaging. And left upper lobe collapse shows that really nicely. The left upper lobe is actually in front of the left lower lobe. It's anterior to it. So when it collapses down, really what you see is just this kind of vague haziness of the left lung. And that's consistent with left upper lobe collapse. Left lingular consolidation. So your left lingular is not a separate lobe. It forms a part of your left upper lobe. Left lingular consolidation just gives you some fuzziness of the left heart border, and you can see it's not a nice distinct left heart border. And then with left lower lobe consolidation, you'll see loss of the left hemidiaphragm medially, so towards the center of the picture, and you'll see sort of, again, probably some loss of the left heart border, but a kind of triangle-shaped wedge cutting through that cardiac border. So that's the lingular consolidation and that kind of triangle-shaped wedge going through the left heart. Breathing, the next part of it would be looking at the pleura. So the pleura is a micrometer width lining of the lungs, and it's not visible in health. You may just see the border of it during sort of set pathology. So pneumothorax and pleural effusions are the key ones you're looking out for. I'm not covering pleural plaques and pleural thickening because I don't think they're going to trouble you too much in the acute setting. With a pneumothorax, it's always really important to look for what we saw on one of the first slides, which is if you see pneumothorax, look straight for the trachea and work out how bad the pneumothorax really is, how urgent you need to intervene. So once you see this, you can see quite nicely a pneumothorax here. Have a look at the trachea. And pleural effusion, and probably another note on pneumothorax is be really, really careful about COPD, bullous COPD, and pneumothoraces. The first image there is reasonably clearly a bully, but a lot of people would mistake that for a pneumothorax that's affected the right upper lobe. The reason that you can distinguish between the two pictures is you can see the image on the right has a clear rim. There is clear lung lining that you can see, which you can't see in the image with the bully. So that rim is highlighted in red. If you can't see that rim and your patient looks mysteriously well for someone who's got COPD and you think has a pneumothorax, which chances are they don't have a pneumothorax and they've just got bad bullous emphysema and they're breathless for some other reason. So it's worth getting a formal radiology report if you're not sure, or asking a senior for help. Failing that, if no one's sure, then no radiologist in the world would turn down a CT if they can't be certain of a pneumothorax on X-ray. Moving on to C, so your heart, looking at your heart size, so usually on a PA film, a posterior anterior film, you'll be looking at the cardiothoracic ratio, and your heart should occupy less than 50% of your hemithorax in terms of its width. We've discussed looking at the heart borders and how they kind of change according to lobar collapse and various degrees of consolidation, but it's also important to look at the interstitium. So those lines that we were talking about, see if there's evidence of fluid overload, and have a really careful look at the costophrenic angles. I don't think you'll get as many cases that are as clear-cut and cardiac as this one, but they do illustrate the points well. So you can see that's the sort of thoracic width, and that's what you're measuring to look at your cardiothoracic ratio. And clearly the red arrow is more than 50% of your blue arrow. And then the other markers as well, he's got a pacemaker. You can't really see either of the costophrenic angles, they're blunted, and he's got some fluid in that last little oval in the middle of the picture. You can see there's a line cutting through the lung. That's fluid in the interlobar fissure, in the horizontal fissure. D is the diaphragm. So not quite as much as in this X-ray, but it's worth mentioning that your right hemidiaphragm is usually slightly higher than the left, and that's because of the liver. Have a look for free gas beneath the diaphragm, and this is usually on the right, and you're looking for pneumoperitoneum. So a perforated viscus where you can see gas underneath the diaphragm. On the left, it's usually the gastric bubble. If it looks like you can see bowel underneath the diaphragm in a patient who's got no abdominal symptoms, especially on the right side, that's known as Chilaiditi's sign, and it's really just bowel transposed between the liver and the diaphragm. It's nothing to worry about. And again, have one really good look at the costophrenic angle to make sure you're not missing a pleural effusion or subtle consolidation that's blurring the diaphragmatic border. So that's what your sort of vague, blunted diaphragmatic consolidation with or without an effusion would look like, with or without, yeah, consolidation would look like. And then E is everything else. Really careful look at your mediastinum. So that's kind of highlighted at its superior aspect by the aortic knuckle and the aortopulmonary window. Look carefully to see if you can see things bulging out from there that look untoward. So it could be a goiter, it could be masses. And look very, very carefully at your bones. The chest x-rays are notoriously difficult because everyone focuses on the lungs and the heart, and people forget to look at the bones, and there's an irritating number of bones on a chest x-ray. Soft tissues, you can sometimes see surgical emphysema. You might be able to see evidence of a calcifying hematoma. And then lastly, lines, valves, and devices. You may be asked about to check the position of these things as well. So looking at the bones, as I said, there can be some rib fractures can be really, really subtle. So you're just looking for a slight break in the confluence of your rib border. And when you see one, I think it's really important to look for a pneumothorax or the sequelae of a rib fracture. So pneumothorax, hemothorax, but then also go back to the patient and make sure they've not sustained any other injuries, especially if you see an unexpected rib fracture. You know, have they fallen over anywhere else? Have they got head injury? Carefully look for surgical emphysema, and have a look for soft tissue injuries that you might be able to pick up on a chest x-ray. They'll normally look like a more sort of dense white within the skin, within the soft tissue surrounding the bones. Tubes and lines. Sadly, there's more of these x-rays happening because we've got more patients with central lines and intubated on intensive care. So your NG tube, this is broadly speaking what you're looking for, but be really careful with this. Every trust will have a clear protocol on when NG tubes are safe to use. But if a nurse or anyone asks you, can you check this NG tube and say it's okay to use, I would clarify what's being done in your trust with regards to NG tube placements and feeding. So traditionally, it should bisect the carina and it should sit under the diaphragm, well under the diaphragm, and in the stomach. My trust, they've got a clear policy that radiologists will report it, and it has to be reported and documented in the notes before it's safe to use. Endotracheal tubes, that's arrow 1, should sit about 4 or 5 centimeters above the carina. And central venous catheters, this patient's actually got a PICC line, and you can see coming in, that's arrow number 2. That should sit at the level of the carina or just above. And you'll normally look for the cavo-atrial junction. Arrow number 3 is the NG tube we discussed a moment ago. And then finally, your review area. So these are places which you've probably already been through, but it's important to go back because this is where things tend to hide. So your lung apices, look carefully for a subtle pneumothorax, masses, nodules, or fractures. Look very carefully behind the heart for masses, consolidation, or subtle left lower lobe collapse. That's a typo, I'm sorry about that. Carefully behind the diaphragm for similar pathologies. And really look carefully at the peripheries of the lungs. Usually, you wouldn't expect to see lung markings in the sort of peripheral 1 to 1.5 centimeters of the lung on a chest x-ray. If you can, it may well be that there's evidence of pulmonary edema or there's some interstitial lung disease, especially if it's fairly diffuse. So just have a really careful look at the peripheries of the lung. And then lastly, the hilar, have a really careful look. COVID-19. So I think COVID-19 is really, really hard when you see the chest x-rays coming in. And in terms of how it's presenting, it's virtually impossible because, we do chest x-rays on everyone that comes in, not just people with respiratory complaints. And I think we're picking up a lot of pathology on patients who've come in for completely unrelated reasons. Broadly speaking, this is what you might expect to see. So consolidation, and that's sort of the dense white that you can see in the left lower lobe of this picture. You might see some ground glass opacification. Ground glass opacification we'll come back to later. Traditionally, it's something that's been described on CT imaging rather than chest x-rays. But because we're so used to kind of interpreting both chest x-rays and the CTs, and what they look like and what they correspond to, I think we're getting better at calling it on chest x-rays, but that's not something that's expected of the sort of shop floor clinician. The changes are usually bilateral. That's about 75% of the time, but you can get unilateral changes. Typically they're peripheral and it's lower and mid-zone predominant. And these are two other x-rays of fairly early COVID-related disease. So you can see the first x-ray, it's bilateral change. It's a much more reticular pattern spreading out from the center and sort of outwards. But you can also see in the kind of top third of the lungs that actually there's lung markings, coarse reticulation or lines that are extending all the way out to the periphery. So that's clearly abnormal. That's not your normal lung markings. And then the last one is probably sort of when he or she is approaching more severe disease, and you can see some air bronchograms forming, especially in that right mid zone. There's a nice clear air bronchogram. It's forming more consolidative disease. I suspect this patient has some bacterial superinfection as well, but it's clearly much more aggressive disease. But the chest X-rays highlight how variable COVID can present on a chest X-ray. Generally, what it doesn't present as is dense lobar consolidation, and almost I don't think there's been any documented cases of pure COVID pleural effusions forming. Viral pneumonia in general tends not to cause pleural effusions. Of course, if you have a bacterial infection over the top of it that then causes a parapneumonic or an empyema, then it may do, but I think that patient will be well into their disease course and it'll be picked up in other ways. And this is what it tends to progress to. So we were talking about the ground glass that you sometimes see, or sometimes what it's been described as. And this is that sort of ground glass pattern, which is just really sort of sandy, thin glass type thing, type substance that you can see on an X-ray. It doesn't look like extensive consolidation, but just looks sort of hazy throughout. And this is really the X-ray of acute respiratory distress syndrome. That is what these patients go into, often within a matter of hours to a few days. ARDS in itself is defined as an acute course less than 7 days. In truth, a lot of the COVID patients are going into ARDS much, much quicker than that. Bilateral changes, bilateral infiltrates on a chest X-ray that isn't fully explained by cardiac pulmonary edema. The reason for saying cardiac pulmonary edema is if you were to do a bronchoscopy on these patients, the fluid within the alveoli won't be sort of transitive, for a lack of a better word, clean heart failure fluid. It will be exudative inflammatory fluid that's leaking out from the capillaries into the lungs. And they have a high oxygen requirement. So the way the intensivists look at it is their PaO2 to FiO2 ratio, or the PF ratio, and they have a very high PaO2 to FiO2 ratio. Sorry, very low one. This is the picture of a diffuse viral pneumonitis. CT imaging, so this is sort of some early COVID disease, and you can sort of see in the lower zones and some of the lower aspects of the upper zones, there is some ground glass, and that certainly in the cross-sectional image on the right, on the left, you can see some ground glass changes there. That's that kind of haziness that we're talking about. And this is from the Chinese data. This is what it tends to progress to. So day 5, this is a slightly more hopeful series of pictures in that you can see that some people do get better. The top 3 pictures are day 5, which is usually when patients really deteriorate if they're going to. And you can see there's really some extensive ground glass consolidation, which is really forming into dense white consolidation all over the lung. And thankfully, this chap recovered. And you can see that his consolidation is actually clearing up. The British Society of Thoracic Imaging, these are some of the descriptions you'll see on your chest X-ray reports and on your CT reports for COVID patients. And radiologists are being encouraged, because of the high variability in what COVID can look like, to use this for a lot of their imaging, even if it seems like it's not COVID at all. They're being encouraged to say this is not COVID, or this is probable COVID, or it's classic COVID, just to help out clinicians on the shop floor. There is no reason to CT a COVID patient unless you're looking for a complication of infection, or unless you're querying an alternative diagnosis. So just because a patient's coming with COVID, a CT adds nothing in isolation. In truth, often chest x-rays don't add a lot except for ruling out other diagnoses. So if you've got a classic COVID patient, they will all get a chest x-ray, but there's no need to CT them to prove that it's COVID. I'll give a brief word on CT imaging of the chest, but I'm not going to run through a lot of CT scans. Broadly speaking, there's 4 different types of CT imaging of the chest that I conventionally use. Your standard CT chest without contrast is just a normal spiral CT of the chest with equally spaced slices taken to give you a picture of the chest. A CT chest with contrast enhances any tumours or masses or vascular lesions, and it also enhances the lining of the lung, which is pleura. And you're looking mostly for cancer and infection. That's what enhances with contrast on a CT chest with contrast. High resolution CT chests are done without contrast. The reason we don't do these for everyone, for everything, you know, the question will be, why don't we do a high resolution scan for everyone? Is because you do lots of thin slices taken at wider intervals, and you're really looking for the detail in the interstitium of the lung parenchyma. So if you imagine you could try to do that for a nodule patient or for a cancer patient, there is a chance that your wide interval means you'll skip a mass. So it's not really a great scan to do for cancer. And then lastly, the one we do most often, the CTPA, the contrast here is actually enhancing the pulmonary arteries and the pulmonary vasculature to look for filling defect or clot within the pulmonary vasculature. It's the gold standard test to do for pulmonary emboli, and it's also the first line test that you would do in hemoptysis as well. So if a patient comes in with large volume hemoptysis that you need to image straight away, CTPA is the one you do. And speaking of CTPA, again, the clear thing is it's not your responsibility to diagnose PEs radiologically, but large central PEs can be easy to spot. The first image shows a saddle PE, and you can see that big grey line in the middle of that sort of Y-shaped, the Y-shaped pulmonary arteries. That's that big grey line running through it is the saddle embolus. And then you can see those sort of dots in the right pulmonary artery on the next CT. Those are all filling defects in keeping with a PE. I'll press again. I'm an ST6 respiratory reg. I have an anticoagulated someone on the basis of my eye on a CTPA. I probably would do it, but I just think if you've got radiologists there, they are the ones that they're the ones that will tell you that a PE is there and that you need to treat it. I wouldn't take a chance on it, especially if you're not used to assessing bleeding risk with empirical anticoagulation. So just be careful. It's useful to know what's going on so you're not then hunting down other things if you can see it easily, but I'd let the radiologist do their job. That's all for me. I've left some time for questions, so by all means, I'll have a look at some of the questions that are on now.
Yes, thank you so much, Sunit. That was a really interesting session, and I certainly feel a bit better informed about something which I'm sure we're going to be expected to look at a lot of. There are a couple of questions. So the first question, looking at the rib fracture, could you give us some pointers on how to distinguish a fresh versus an old fracture of a rib?
Yeah, so obviously, aside from clinically, so if they're in pain, then obviously it's a fresh rib fracture, but your fresh rib fractures will show a break in the border of the rib. Old rib fractures will kind of look more like an oval callus shape around where the old fracture was. So you'll kind of see that it's a smooth border, but it's just kind of smoothly protruding out because callus is formed around it.
Brilliant. And we saw those really quite marked reticular lung markings in that first COVID chest film you showed us. What is it that causes those reticular markings?
So in viral pneumonia in general, interstitial exudate. So these patients are going into ARDS and they're getting a lot of, in COVID, it's because there is, a lot's been said about this cytokine storm. So they're getting a lot of capillary leakage of inflammatory fluid into the interstitium. That can then fibrose, but I don't think we've got the follow-up imaging to show that, but it's just fluid leaking from, inflammatory fluid leaking from capillaries in the lung.
And finally, I've got a question which is certainly above my level. So I'll ask my question first, which is, what is PaO2 versus FiO2? And Alan Joseph would also like to know how to calculate it.
I'd recommend, so I mean, it's as straightforward. It's exactly what it says on the tin. So your FiO2, you express it as a single digit, so 100% would be 1.0 and 60% 0.6, and it's your PaO2 in kilopascals divided by that. I would suggest you use MD Calc. In truth, the ARDS definition is a PF ratio of less than 300 millimeters of mercury, so the Americans use millimeters of mercury. It is ARDS, and there's various degradations of the severity. It's almost irrelevant. Essentially, if you need a lot of oxygen to maintain your saturations above 92%, that's essentially ARDS. And the intensivist, when you're calling up ICU, they won't be asking what's the PF ratio. They'll be saying, oh yeah, we'll come see the patient if they're on a lot of oxygen. So that's how you do it, but it's not useful clinically.
Thank you so much. We'll take a little break now, and everyone can get a cup of tea. So thank you very much for bearing with us. I'd now like to introduce Dr Catherine Ashton, who's a specialist registrar in care of the elderly at the John Radcliffe Hospital in Oxford, and she's going to be talking to us about an approach to an acutely confused or agitated patient.
Good evening. I'm just going to share my screen so you can all see. And hopefully you can all hear me. Yeah, so I'm Catherine Ashton. I'm an elderly care registrar, and I'm going to talk about the approach to the, and I said older patient because that's really my area of expertise, and a lot of the younger patients generally who are approaching with agitation are often seen by psychiatry at the front door more than ourselves. So what I am going to cover is assessment of the confused patient and a bit about how we differentiate delirium from dementia, psychosis, and also I've thrown depression in there. Understand who is at risk, understand what may cause delirium, management of the confused patient, and a reminder of the Mental Capacity Act and DOLS. And I'm going to refer back to this case a few times just to give you something to base this on. So Mr. Jones is a kind of typical patient that we may see. So he's been referred to the medical take from the emergency department. He's an 86-year-old referred because he is off legs. He's been more confused for the last 3 days, not eating and drinking, wanting to pass urine more frequently with some new incontinence, and he's not been able to get out of the chair today. And the first thing I wanted to say is there isn't really a typical presentation, so it's very difficult for me to kind of give you a classic example. These patients who present with confusion or agitation present in all sorts of different ways. Some of the common things that we see is immobility, lethargy, unable to care for themselves as much as they normally would do, being generally unwell. Sometimes they present with hallucinations or generally just very bizarre behaviour. And what's actually reported? So this is kind of what we often get from the relatives. So mum's not quite right, something has changed, the neighbours found dad in the street, somebody can't cope, and also dad's not making sense. Other terms that you will see that are kind of synonymous with this is confusion query cause, acute confusional state, acute organic syndrome, postoperative psychosis, organic psychosis, and then terms like not quite right, poor historian, off legs, and acopia. So delirium, what is delirium? Well, it's disorientation in time, place, and or person. There's often impaired concentration and attention. There's an altered cognitive state, impaired ability to communicate. Often there may be increased wakefulness, but they also may have insomnia or kind of reversal of their sleep-wake cycle with nocturnal agitation. They may have reduced cooperation, and they may be irritable and aggressive. Another way that I kind of think of it is acute brain failure, just like acute kidney injury, decompensated cardiac failure. Acute brain failure is generally how I think of it in my brain, and they may or may not have had previous brain failure or previous delirium. It can be recurrent, just like anything else. It could be acute on chronic, so they might have chronic brain failure, also known as dementia, and it can lead or precipitate worsening of cognition and reveal an underlying dementia type process. The things that we look for is obviously somebody just being more confused. They often will have quite a poor attention span, so it's often very difficult to get a history from these patients. They may repeat questions, they may perseverate, they are often distracted, they might be looking around the room or agitated, plucking at bedclothes is kind of the classic thing you might see. They may be hallucinating, and it's normally visual hallucinations typically that we see. On the opposite side, they might actually be very quiet or drowsy or withdrawn, and they are often very disorientated, and as I've already mentioned, not able to care for themselves as they usually would. So often, you know, relatives will say, oh, dad can normally get himself up and dressed in the morning and he's just not able to do that at the moment, and loss of mobility from whatever their baseline is. So back to Mr. Jones. So we're taking a history from him. He's got quite tangential speech. He knows that he's in hospital, but not necessarily what day or year it is or what time it is. The only thing he reports is that he needs to pass urine. He's not able to give us any additional history, and this is a really common problem that we face. We do have access to prior medical history and medications. So he's got a background of hypertension, diabetes, depression, and osteoarthritis. And his medications you can also see there on the right-hand side. I'll just let you have a moment to take note of them. So he's examined, he's looking around the room, he's disorientated. The only kind of significant finding is that he's got a slightly distended abdomen, but nothing else significant on clinical examination. And his observations are recorded there as well for you. So who would we typically see this in? So predisposing factors. So if somebody already has cognitive impairment, that is a predisposing factor in itself. And we see a 2.5-fold increase in the risk of delirium in patients with dementia. And about 1/3 of those with a delirium will have an underlying dementia, but it may or may not have been diagnosed. Obviously, advancing age, male gender, medical comorbidities, polypharmacy, visual impairment, hearing impairment, being physically frail, and frailty is something that we're talking a lot about in the current COVID climate, underlying history of depression and a history of alcohol abuse. And the kind of differentials for delirium or acute confusion that I generally think about are depression. So often these patients are withdrawn, they might give more negative answers, they normally have more insight, and the onset is generally a bit slower, but this is kind of typically, but not always. Their cognition is not usually impaired, but sometimes you really have to push them to be able to test that. Dementia is obviously irreversible. If this is progression of dementia, they don't always have changes, rarely have changes in conscious level, and the onset is generally over months rather than an acute decline. But it may be that for whatever reason they've now ended up on your medical take because nobody is able to manage their care, for example, or people are concerned about their safety. And then psychosis, which may overlap, but usually the consciousness and cognition are not impaired. but again, similarly, they may have onset over days or weeks. And I find this table really helpful, so you'll be able to go back on these when the talks are uploaded, but this just gives you a bit more information about how you can differentiate delirium from other similar conditions. But the fact is that delirium is generally very acute, it generally fluctuates, it's a much more acute onset, generally over hours to days. Conscious level is normally altered, attention's impaired. They can have a hyperactive delirium, so they may be very agitated, or they can have a hyperactive delirium, so they may be very withdrawn and drowsy. And it's actually those with the hyperactive delirium that we worry about more, because they're the ones that don't get the attention and are more difficult sometimes to diagnose. So going back to Mr. Jones, so he has an ECG done, which is normal sinus rhythm. He has a chest X-ray, which shows no consolidation, and his blood tests are there in front of you. But reasonably unremarkable compared to his baseline is what I would say, because often, obviously, we have to look at what their previous blood results are and why. So, why do patients become confused? What is the precipitating factors? And pinch me is a mnemonic that I've always remembered from medical school, and I find this a really useful sieve to go through to think about why somebody may be acutely confused. And I think it's really important to say that often it's not one precipitating factor, often it's a multitude of factors that you need to look for. And pain is really underreported in the elderly. I think a lot of them are very stoical, but also a lot of people will just not tell you that they're in pain. Think about physical restraints, including catheters, because they are all things that might precipitate this. Obviously, infections. I think urinary tract infection is the old classic, but believe me, not many people, as would like to be believed, are suffering from urinary tract infections. Obviously, things that we do to patients, so surgery, for example, will make people potentially more confused. Ischemia, so stroke, MI, reduced nutrition. Coming on to C, constipation is really, really common in the elderly. I think all the junior doctors I work with think that I'm just obsessed with bowels, but it's a really common precipitating factor for delirium. And older people who are less mobile are much more risk of getting constipated. Obviously, brain pathology will also precipitate a delirium. And hydration is another big thing. We all know that our elderly patients don't drink enough, and it makes me laugh when we put elderly patients on a 1.5 litre fluid restriction, because the reality is that particularly the old and advancing age really don't drink that much fluid. And medications is another big one. So similar to our pharmacists, geriatricians often go around with their pen or their mouse, as a lot of them are electronic records nowadays, but crossing off medications. And the common things that we see are opioids, anticholinergics, sedatives, antidepressants, steroids, all precipitating a delirium. And for those of you that haven't heard, I just want to direct you to the stop-start criteria, which gives lots of information about which medications to stop and start in elderly, and it's a really useful kind of prescribing hint. And then finally, environment. Once somebody's in your hospital, they're out of their natural environment, and there's not necessarily a lot that we can do to change that, but I'll touch on how we can improve the environment. Alcohol withdrawal as well. We're not very good at asking the older patients about alcohol and illicit drug use, but it does happen. And certainly I always ask my older patients about alcohol intake. Electrolyte disturbance as well, so particularly hyponatremia and hypercalcemia are the two common things that will precipitate a delirium. and then finally I think about endocrine. So hopefully that's kind of a useful mnemonic for you to sift through next time you're seeing the older person who's confused, just to think about what may be precipitating it. So I've done a quick poll just for you to have a think. So for Mr. Jones, what do you think are the most likely causes of his delirium? And you've got a few options there. I will bring up his blood results because I suspect that's probably the most useful thing.
So I'll let it get to a good percentage of people having voted, and then I'll let you all see the results. So that's just under half. Just give it a few more seconds for the rest of you to make your decisions. There we go. Catherine, can you see that?
I can't see the results.
Ah, well. The most common choice is dehydration, with about 60%, and then urinary tract infection, about half, constipation, hyponatremia. No one has gone for anemia or stroke, really, with all the others having about a 10-20% share.
Thanks. So what I would say is, I think definitely dehydration could be contributing. He's got a slightly distended abdomen and he was on codeine regularly, so constipation is often a common thing that I would rule out. His sodium's probably not low enough to be contributing. He's certain anemia is not a cause of delirium. Again, the amitriptyline might be contributing as well. He may have ongoing pain. We've not really gone into too much detail, but I think certainly the things that I would consider are pain, constipation, dehydration, and his amitriptyline and codeine also contributing. And he may have been on those a while, but it's generally, as I've already said, a combination of all these things that contribute. Urinary tract infection is a possibility. His inflammatory markers aren't significantly elevated. And I will come on to why I'm not considering that as a very likely option in a second. So, why? The honest answer is we don't really know why this happens. The main theory is that there's reversible impairment of cerebral oxidative metabolisms with neurotransmitter abnormalities. And certainly if we think about some of the medications that contribute to delirium, that may confirm that. But the honest answer is we don't really know why. We do know that sleep deprivation is also a possible contributor, and we know that people's sleep hygiene, particularly in hospital, is very poor. But the honest answer is there's lots of theory, but we don't really know. but it's really important that we recognise and treat it. And the reason is that there is significant associations with high mortality. We've already mentioned that it may accelerate underlying cognitive impairment, and it's also really important that we recognise where people may have more chronic cognitive impairment so they can have diagnosis and therefore support and potential medications and treatment, etc. These patients are more likely to be institutionalised, they're more likely to have an increased length of stay, and there's also kind of a post-traumatic stress element of this. A lot of patients that people see in intensive care are very distressed by the delirium process that they have there, and I think we're very good at following it up in patients in intensive care, but not necessarily our older patients that have been on a general medical ward. So how do we diagnose it? Collateral history is often key. Unless you've met this patient time and time before, often we don't know what they're like normally. There may be the very obvious person who's trying to get out the ward, who's trying to hit the carers, who's very agitated, and it may be more obvious in them, but we just don't know what people are like outside of hospital. So collateral history is often key. There are a couple of tools that different hospitals will use. So the first one is the confusion assessment method, or the CAM tool, and basically you have to recognise that your patient's got an acute onset and fluctuating course of this, and they have an element of inattention, and then either on top of that they've got disorganised thinking, so they might be rambling, illogical, tangential like Mr. Jones, or an altered level of consciousness, and they might be more hyper alert, or they may be more drowsy. And that's got a really good sensitivity and specificity. The other tool that other hospitals might use, which reportedly is less sensitive and specific but still very good, is the SuppoRTT. So that's looking at somebody's level of alertness, looking at their orientation, looking at their level of attention. So often it's counting the months, stating the months of the year backwards, and then again the acute change or fluctuating course that we saw in the other tool. And why is it missed? Well, often on our ward rounds we're so busy that we go in with our own agenda. We are very guilty when we're on a medical round of giving patients very closed questions. So I think sometimes just allowing the patients to talk reveals more about their cognitive state. We're very bad at assessing cognitive function. You know, it's just like the neurologist would probably say, very common, that we're not very good at doing a neurology exam. I don't think we're very good at trying to examine or look for delirium. We often assume that cognitive impairment is long-standing in older patients. We're really bad at talking to nurses, especially the night staff, because it's often at night, so we talk about sundowning, it's often in the evening and overnight when we've gone home that these patients are more delirious, and they might be as nice as pie during the day, and without that collateral history from the nurses and the night staff we might not pick up on it. We're not very good at talking to families either, and particularly in the current climate where we're not having visitors, we're having to pick up the phone more and more to find out what is this person like normally. If somebody's withdrawn, we often think it's depression. We don't think that this could be a hypoactive delirium. And again, if a patient's noisy, we might just start a benzodiazepine and not really think about why is this patient noisy, why are they agitated, what's going on. So we get a collateral history from Mr. Jones, like any good geriatrician, and we find out that he's occasionally forgetful, and it's really interesting what people perceive to be normal aging and normal memory loss. Cognitive impairment is not normal, and memory loss is not normal in elderly patients. So for example, his relatives have said that he missed some hospital appointments, he got on the wrong bus, he sometimes forgets the grandchildren's names, and sometimes people are quite forgiving that this is very normal and to be expected in older people. Whereas if somebody was telling me this, I'd certainly be concerned that there was mild early cognitive impairment. He lives alone in a bungalow, his daughter does heavy shopping, he eats ready meals, so actually his level of function is not fantastic. He drinks 2 to 3 glasses of wine per night. Maybe I'm a lightweight, but if I drank 3 glasses of wine per night, I would be having a long lie-in the next day, and he's a non-smoker. So, management. How do we treat such patients? And I'm just going to give you a few photos that I've acquired along the way. You need to think about like a disorientated older person to maybe appreciate the points that I'm getting at here. But the photo on the left, to us, that's obviously just a hospital floor and the reflection of the lights. But to an older person, that floor might look very wet. It might look littered with obstacles, particularly if your vision is impaired. You're not going to be very clear. So it's no wonder sometimes that our patients are scared about mobilising over such a floor. The picture on the right, is that the patient's reflection, or is that someone getting it into a lift? Is that a room being occupied and the patient can't go in there? The picture on the left, I would say those stairs are going down. But if you look at it again and think like a disorientated patient, are those stairs actually going up? The picture on the right, crazy carpet. I've no idea where the edge of some of those stairs are, and I think no wonder that if you're slightly confused and disorientated, you lose your mobility, because probably you can't see very well where you're going and what you're walking down, and you're probably scared of falling over. And then finally, the carpet or the rug on the left, is that steps? Is it a big black hole they're walking into? Are those flowers around the outside? And the picture on the right, is that a carer coming to the door, or is it an intruder? And sometimes just looking around your ward and thinking like a disorientated person who's slightly visually impaired, you'll be amazed actually at how many obstacles there are and why the environment can be quite frightening. So to prevent it, you need to think about your patient as an individual. You need to try and reorientate them. You need to think about their hydration and nutrition. Familiar objects are really important, so asking relatives to bring in photographs or books that they enjoy reading. Sleep hygiene, as I already mentioned, is really important. The wards are so noisy at night if you actually go and talk on one, and no wonder our patients can't sleep at night. Think about hearing and vision. There's no point a patient having their hearing aids in a box on the table. Their glasses are often just left to one side. Review the medications. So as I've already mentioned, have a look at the stop-start criteria online. Think about bladder and bowel care. Think about mobilisation, and because maintaining mobility will also help these patients. And think about pain control as well. And actually, the most important thing to state is that you often need to do multiple of these things, but it can lead to a risk reduction of up to 30%. From a Cochrane review in 2016. So it's really important, just like we think about multiple causes for confusion and delirium, there's multiple ways to manage this. Going back to the environment, a calm, reassuring, safe environment is what we advocate. Bed rails often can be a hindrance. We think that we're doing a good thing to keep the patients in the bed, but actually the reality is that people get agitated, they feel restricted and restrained, and they just get up and fall over the top of the bed rails. Thinking about the glass and hearing aids, think about trying to maintain a quiet environment and a well-lit room where possible. Try to orientate them. Staff and ward continuity is really important. I think staff continuity these days is really difficult to maintain. But if you think about an older person who comes into your emergency department and goes on a tour of the hospital, there's a lot of disorientation there. No wonder they've got no idea where they are whenever they end up on their kind of end ward. Avoid constipation, as I've already said. Regular analgesia. If somebody's come in and they've fractured their pelvis, they might not always ask for pain relief, but it's likely that they're in pain. So have a think about that. And most people, you're safe giving regular paracetamol to. Involve the family. Sometimes they can come in and help with meals or help settle a patient if they get more agitated in the evening. And really, sedation is the very last resort. Also think about all the underlying causes, all the underlying precipitants that we've talked about before. And generally, I would say start by assuming an underlying cause. I'm going to move on to talk briefly about sedation. This is not something that I advocate, and this is very much a last resort. There's no evidence that it prevents delirium, but it may be required if somebody is in significant distress or is a danger to themselves or the staff or the people caring for that person. And you occasionally will require it for investigation or treatment, but again, I would say a last resort. You know, if somebody's needing intravenous antibiotics and they're pulling out their cannulas, have a think about actually, could somebody come back in an hour or two and try again to put the cannula in, or try again in an hour or two for their scan or the X-ray, rather than sedating people. The general medications that we use is haloperidol, risperidone, or olanzapine. Think about the QTC, make sure they've had an ECG. Think about extrapyramidal side effects, particularly with haloperidol. But usually haloperidol is first line. That's certainly nice guidance, obviously except for those with Parkinson's disease. Use a low dose. You can always give more, but what you don't want to do is oversedate these people, because then there are all sorts of risks, but particularly pressure damage and pneumonias. Generally, I try not to write it up regularly in the first instance. I generally put it as required, and this can be given at 0.5 milligrams intramuscularly orally. Think about putting on a review date as well. And I think if you're starting someone on a regular antipsychotic, those patients really should be having mental health follow-up. Olanzapine again, use low dose. Similar advice really, make sure that you've got a review date, make sure that they're getting follow-up. It is slightly better tolerated long term, but actually most of these patients, if they've got long-term confusion, actually the problem there is dementia rather than delirium. And again, older people's mental health should be helping us to manage agitation in somebody with dementia. Benzodiazepines I generally avoid. The Cochrane review in 2009 says that there's no adequate control trials to support the use of benzodiazepines, but in somebody who's withdrawing from alcohol, is having sedative withdrawal, or who has Parkinson's disease, it may be a slightly better option. And again, low dose, because you can always give more. And the complications of delirium, so falls, pressure sores, hospital-acquired infections, functional impairment, continence, all the risks of oversedation, as I've already mentioned, and malnutrition. So there's loads of complications, and that's why it's so important that we recognise it early, diagnose it, and try to treat it. And I think, as I've already said, after a delirium, it's a very frightening experience, particularly those that can recall it and have insight. And there's often a lot of embarrassment associated with it. So you need to reassure people, you need to give them information, and particularly the relatives as well, because they're often the people that find it even more distressing than the patient themselves. And as I've mentioned several times, think about, could this patient have an underlying dementia type process, and do they need follow-up in memory clinic? So going back to Mr. Jones, so I would stop his amitriptyline. For example, I've said that it was started after his wife had died, and often ask patients who are on antidepressants or on painkillers, why are you on these painkillers? Why are you on these medications? Stop the ramipril. He was slightly hypotensive. It will also contribute to falls. You might also think about stopping his amlodipine. Regular paracetamol, as I've said, because patients, if they're in pain, for example, with their arthritis, won't necessarily ask for pain relief, but paracetamol is going to be less harmful than regular codeine. Think about stopping the lansoprazole, rehydrating them, treating the constipation. Check the calcium. He was on Adcal, and as I've mentioned, electrolyte disturbance is a common thing. So his was slightly high, so you might be able to reduce that. Bladder scan is really important. So actually, is this gentleman going to the toilet more frequently because actually he's in urinary retention and he's having a bit of overflow leaking? And that's something, particularly in men, is really frequently missed. So in all older people that come in delirium, I have a very low threshold to do a bladder scan. It's a really easy bedside test. We don't do urine dips. We don't advocate urine dips to diagnose infection in the elderly. It's about as good as flipping a coin. And actually, there's some evidence to suggest that the smell of somebody's urine is more specific for diagnosing a urinary tract infection. So if you suspect somebody's got a urinary tract infection and they're elderly and they've got symptoms, we generally would say send a urine culture and start on antibiotics per the local guidance, but have a think about what those infection markers are doing. I think his white count was 10 and his CRP was 15. If you're not sure, that might be something that you can watch and wait and send a urine and then see what it comes back as. And then again, think about the environment, think about orientating these people, trying to provide consistency. This Is Me is a really good document that people may have seen. So asking relatives to fill in information about this person. What do they like? What's their background? What was their job? And things that might help you orientate them and reassure them. Think about activities. Do you need to admit these people at the front door? Sometimes these people, admitting them to hospital can make things worse. Think about that change in environment. And then in the last, we've got about just under 10 minutes left. I just want to touch briefly on mental capacity and the deprivation of liberty safeguards. I'm not an expert on this, but it is something that I think it's just useful to think about alongside your confused and agitated patients. So the Mental Capacity Act in 2005 stated that we should presume capacity and we should support people to make their own decisions. We shouldn't assume lack of capacity if people make unwise decisions. We should always act in the best interests, and we should always use the least restrictive approach. And most importantly, an assessment of capacity is decision and time specific, and capacity may change. And the 4 key things are: can they understand the information to help make that decision? Can they retain the information? Can they weigh up that information? And can they communicate their decision to others? And I think if you're assessing somebody's capacity, whether that be with regards to treatment or discharge destination or anything, I think it's useful to think about it in these 4 domains if you have concerns that they may not have capacity. And certainly when documenting, if you document a decision regarding somebody's capacity based on these 4 domains, I think medico-legally that's very good. If the patient lacks capacity, what do you do? So first of all, think about, do they have a valid and relevant advance directive to whatever the decision is that you're making? So for example, if somebody has end stage multiple sclerosis, have they got an advance directive regarding feeding tubes, for example? Do they have a lasting power of attorney? And importantly, lasting power of attorneys are two separate things. So there's one for finance and there's a separate documentation for health and welfare. And obviously in medicine, generally what we're interested in is, do they have lasting power of attorney for health and welfare? And these people only come into play once the patient loses capacity. So often somebody might say, I've got lasting power of attorney for mum and I don't want her to be discharged home. But actually, if mum's got capacity and has made, we might think, an unwise decision to go home, there's not a lot that lasting power of attorney can do about it. If they don't have an advance directive that's relevant, if they don't have a lasting power of attorney, are there any friends or family to consult with? And often at the front door, I say to people, who is your next of kin? Because generally when you're trying to find that out, it might already be too late. So work out who the patient feels is the most appropriate next of kin. And if not, do they need something called an IMCA, so an independent mental capacity advocate? And this is somebody who can help you as a physician make decisions about their relative, about a patient if they don't have an appropriate relative, LPA, etc. And just to touch briefly on DOLS, so this was introduced and published by the Ministry of Justice from 2009, and these safeguards are designed to provide positive protection for adults in hospitals or care homes in circumstances where their liberty is thought to be deprived, but who lack capacity to the care or treatment that they may need. So if an adult cannot consent to being in hospital and there's an impairment or disturbance in the functioning of the mind and brain, i.e. they've got delirium or dementia or any other kind of process that might impair that, first of all, reasonable adjustments have to be made to allow the person to make their own decision. And the person has to lack capacity and it's unlikely to resolve, and that's kind of where DOLS comes into place. And if you're thinking about, does somebody need a DOLS, what they often say is the acid test is the person being subject to continuous supervision and control? So for example, if you're not allowing somebody to leave the hospital ward, that is continuous supervision and control. Is the person free to leave? Does the person lack capacity to consent to their care and treatment? And if the points all apply, then the person's been deprived of their liberty. And further decisions therefore should be made in the best interest, and a DOLS application should be made to the local authority. And this is something that the geriatricians and often the ward managers will be very familiar with. And these are the kind of things where you might consider a DOL. So is somebody trying to leave the hospital? Are you trying to give them medications, sometimes coercively, feeding tubes, and also mittens and bridles as well? So take-home points for tonight are that delirium is multifactorial. There's often a predisposing vulnerability and precipitating insults. It can be diagnosed fairly accurately using the CAM tool, which is my preferred, but the 480 is often used as well. Prevention of delirium should be our primary goal, but if delirium occurs, think about the underlying causes, think about the pinch me mnemonic. Always try non-pharmacological approaches to management first, but if you have to use sedatives where somebody's either at risk to themselves or other people, or you really need to sedate them to get a test done, very much advocate using low-dose antipsychotics, and think about the legalities of the Mental Capacity Act. So don't assume lack of capacity, act in somebody's best interest, use the least restrictive method, and think about your documentation of that, and also just be aware of when we're depriving people of their liberty as well. And that's all I've got to say for tonight.
Thank you so much, Catherine, for a really wonderful and very timely talk. I've got a couple of questions that I'd like to run through with you, and one which particularly I really wanted to answer live. Obviously, things are very different to how we would ideally like to treat our patients at the moment, and that we're not allowed any visitors in hospital. It's very difficult with staffing, and for our patients, of course, it's probably even more confusing than normal times. Do you have any advice on managing delirium in this kind of strange place that we seem to be in?
I agree. I think it's really difficult. I was trying to explain to a lady who lives with dementia about coronavirus the other day, and I think she definitely was quite convinced I was lying to her. I think ideally trying to use continuous care as nursing staff is often really helpful, because they will get to know the patients. Telephone any relatives and find out what normally the person likes doing. Try to distract the patient, so doing puzzles, looking at books, looking at newspapers. Often elderly care wards will have things like that that can help. Trying to, as I've said, during the day, keep the ward nice and well lit, trying to still get the therapist to mobilise the patients wherever possible. But I agree, I think it's really difficult, and it's particularly challenging in the current climate where people can't visit. But any information that you can get from relatives that might help them, what they used to do for a job, just to kind of open up conversation and take that patient's mind off their current distress, whatever's causing that, can be really helpful.
Yeah, Dr. Sarah Millett, who's another geriatrician who's been very kindly answering lots of typed in questions, has also mentioned a British Geriatric Society guide to delirium in the context of COVID, and covering such topics as patients who are wondering who are an infection risk to other patients and so on. So I guess that might also be useful for people to go and have some further reading.
Yeah, definitely.
So thank you so much, Dr. Ashton, for that wonderful talk.